It's clear that what we have learned in the last 30 years is that the use of transradial access has dramatically reduced the access site complication for PCI. Today, there is another option, the distal transradial approach for diagnostic or intervention. And we have really the chance today to have with us Dr. Adel Aminiam from the University Hospital of Charleroi in Belgium. And he has a large experience on the distal radial access. And I would like to have some details in this access. And we will discuss after his presentation about few key points on this particular procedure.
Thank you very much, Jean. It's an honor to share this symposium with you, and I will give you some insight about this new vascular access. As you have said just a few seconds ago, so radial access now is supported by US and European guidelines because of many advantages as compared to femoral access. But one of the drawbacks of the radial access is the occurrence of radial arterial occlusion, which remains as the most frequent complication of transradial access. And the main complication is that it prevents or precludes the use of the same radial artery for future procedures. 3 years ago, a group of experts, and I had the chance to participate in this consensus document, have depicted very, let's say, easy and effective techniques to reduce the rate of radial arterial occlusion to minimal, at least less than 5%. Despite this very effective and easy recommendations, which can be applied in all cath labs, the real-world reported incidence of radial arterial occlusion remains high in recent publication with a wide variability in the uptake of those very easy, effective preventive strategies. And recently, the distal radial access, which is a puncture of the radial artery in the anatomical snuff box or at the dorsum of the hand, has emerged as a very attractive alternative access. And one of the main feature of this new access is that you puncture actually the radial artery distal to the superficial palmar arch. And this has a consequence, is that in case of occlusion or in case of compression during hemostasis of the distal radial artery, the blood flow is maintained in the forearm radial artery, which prevents retrograde thrombus formation in the forearm radial artery, and as such, forearm radial arterial occlusion. So it's a very effective method to keep the forearm radial artery open. And this has been shown in 2 recent single-center randomized trials as a very effective method as compared to conventional radial artery access to prevent radial arterial occlusion. And those 2 single randomized trials have shown striking reductions in the rate of forearm radial arterial occlusion when you compare distal radial to conventional radial access. And there are other advantages beyond this reduced rate of radial arterial occlusion. One of the main advantage is a very fast and safe hemostasis due to the very superficial position of the distal radial artery and also the bony basement, which is compounded by the scaphoid bone and the trapezium bone. Also, when you use the distal radial artery, you have a very ergonomic position for the patient and also for the operator, especially if you have to use the right wrist, because the operator doesn't have to bend over the patient, and this is more comfortable. But there are many challenges. One of them is, of course, the smaller size of the distal radial artery. On average, it's 1 French smaller than the forearm radial artery. The less predictable curves of the distal radial artery, which makes the puncture more challenging with a high rate of failure. And regarding the reduction in forearm radial arterial occlusion, the current evidence is limited by the single-center design of most trials that have compared distal to conventional, the heterogeneous hemostasis technique, and also the high rate of radial arterial occlusion in the conventional radial group. So there was a need for a large-scale international randomized trial which will investigate the benefit of distal radial with respect to conventional radial access, but providing systematic implementation of best practices to reduce rate of radial arterial occlusion. And that's what we have performed with the disco-radial trial, which was presented at EuroPCR and published in JACC Intervention recently. This study was supported and funded by Terumo. And the goal was to assess the superiority of distal radial access as compared to conventional radial access with respect to forearm radial arterial occlusion, which was the primary endpoint of the trial. So it was an international, multi-center, the first one, randomized controlled trial, and patient with an indication to coronary procedures using the six-French dilated slender randomized 1-to-1 to receive distal radial access or conventional radial access, but with systematic implementation of best recommendations to reduce radial arterial occlusion. And we also took advantage of this large multi-center trial to assess key secondary endpoints, including crossover rates, hemostasis time, spasm, and access seat related complications. So the inclusion criteria were broad to include a patient population representative of current clinical practice. And actually, patient had just to be suitable for both distal radial access or transradial access according to the operator. And we had very few exclusion criteria, which were basically patient on chronic hemodialysis, patient with ST elevation MI, and also CTO procedures. One of the main aspects of the trial that operators entering this trial had to be fully independent with distal radial access, with a minimum of 100 procedures performed through distal radial access to have a fair comparison between the two groups. The statistical assumption was that patient in the conventional arm will have a rate of occlusion of 3.5%, and this was based on the 6 French subgroup of the RAP&BEAT trial. And we have set this rate at 1% for distal radial access, which was relatively conservative when you look at the previous publications. And to have enough statistical power, we had to include 1,300 patients in this trial, and the primary endpoint was radial arterial occlusion. So the inclusion was performed over a 20-month period, which was slowed down a little bit because of the COVID pandemic, but we ended up with 1,307 patients randomized 1-to-1 to receive distal radial or conventional radial. This study was multi-center with 15 centers, mainly in Europe, and also one center in Japan, which was a center from Dr. Saito. And if we look at the procedural characteristics of this trial, you see that the two groups were well balanced in terms of access side, which was the right radial artery in the vast majority of patients. Around 1/3 of patients underwent PCI. You see already that the crossover rate was significantly higher for distal radial access, with around a 3% difference in favor of conventional radial, so more crossover in the distal group. The median insertion of the sheath was slightly but significantly longer in the distal group. When we look at procedural type, contrast volume, radiation dose, there was no difference. The ACT at the end of the procedure was similar between the two groups and reflected the good anticoagulation in both groups. And there was less frequently use of a compression device in case of distal radial access. If you go directly to the primary endpoint of the trial, which was forearm radial arterial occlusion, what we see in this trial is that we ended up with an extremely low rate of occlusion in both groups without a statistical significance. So it was 0.3% in the distal group and 0.9% in the forearm radial artery. So there was a numerical difference, but it was not statistically different. And if you look at the key secondary endpoints of this trial, the rate of spasm was slightly higher in the distal group. You had around 2% difference or more spasm. But if you look at the overall pain of the patient at the end of the procedure, there was no difference. If you look at the median hemostasis time, it was shorter with distal radial access, which is in line with what was published before. And we look at the quality of the hemostasis in the conventional arm, we see that patent hemostasis, which is probably the best method to prevent radial arterial occlusion, was achieved in as high as 94% of patients randomized to conventional arm. If we look at bleeding and vascular complication, there was no difference between the two groups. So if we look at the primary endpoint, which was the rate of occlusion, we see again that if you use the distal radial access, you can end up with an extremely low rate of radial arterial occlusion. And this is in line with what has been published before. So as a single method to prevent radial arterial occlusion, definitely distal radial access is very effective and reflects the physiological rationale that I have depicted before in my presentation. But the novelty here is that when you use the conventional radial access and you apply good preventive strategies, you can also end up with a low rate of occlusion, actually not different as compared to radial access. And it's very important to depict that in this trial, adequate anticoagulation was used in almost all patients, an effective spasmolytic treatment, the use of slender sheet, which is also very important, patent hemostasis in as high as 94% of patients randomized to conventional arm, and also the extensive experience of the operator. All these aspects ended up in this very low rate, which is one of the lowest reported in the literature. If we look at the secondary endpoint, the key findings is that, of course, distal radial access, due to the smaller size and also the less predictable course of the distal radial artery, is more demanding with more crossover, more radial artery spasm. Although once you get the access, it has no impact on procedural duration or radiation dose. And we see that hemostasis seems to be easier with a shorter hemostasis time and less frequently use of a compressive device, with sometimes just manual compression in some of the cases. So if I have to summarize, Dr. Fajadeh, what is actually the current status of distal radial access, what could influence the uptake of this new access, is that, of course, you will have a low rate of radial artery occlusion. The hemostasis will be definitely shorter and easier. It leaves the wrist, as I said, in natural position, so it's more comfortable for the patient. It is definitely an alternate seat if the common radial seat has been recently used or is occluded. And it's also a potential seat for retrograde recanalization of radial artery. But the remaining challenges is that we are still in need of large clinical data to support it. There is a learning curve, and that can be some things cumbersome for experienced radial operators. So you need to invest a little bit of your time to decrease the rate of failure. It is associated with more spasm and pain, especially at the beginning of the procedure, but not at the end. And also, the smaller size of the distal radial artery can be a limitation for the use of large bore guiding catheter if you want, for example, to perform a CTO procedure. And in some patients, you may need a longer catheter length in taller patients. That would, in my opinion, be the remaining challenges for this procedure. So with that in mind, I will thank you for your listening of this presentation, and I'm open to any question from your side, Dr. Fajadeh.
Oh, thank you, Adair, for this really very nice lecture on this topic on the distal transradial access. I'm really fascinated by this technique. Personally, I'm using transradial since 30 years, and I never tried the distal one. How do you explain your really extremely low rate of thrombosis and occlusion, foramen occlusion, compared to the two other trials?
We wanted to have a fair comparison between distal and conventional, and we were a little bit puzzled by the very high rate that we have seen in the two other single center randomized trials. For example, in the DAPRAO trial, the single center from Mexico, the rate of occlusion was around 8%. 8% is very high, actually. So yeah. It means that if you apply effective strategies, you cannot end up with such a high rate. So we wanted to have a fair comparison, and we wanted really to apply best preventive strategies. And we have done that because all the centers were very experienced in radial access, and we have really took a lot of efforts to achieve such a low rate of occlusion, which actually can be achieved by any centers applying the same recommendations, the same strategies. When you end up with 94% of patent hemostasis, when you take such a special care for the hemostasis, you will have the same rate of occlusion. The thing is that it's more cumbersome for the nurse team because you have to take more time for the hemostasis, and that high level of care is not always possible in every cath lab, and that can explain sometimes why in real world practice you have higher rate than 1% in real world practice, and that's where probably the distal radial as the single method, just using the distal radial, can allow you to have a very low rate of occlusion. So I think our results are quite reassuring for people still using the conventional radial access, because we show to them that they have to do a good job with the hemostasis. But we confirm again that when you use distal radial, you will end up with a low rate of occlusion. That is confirmed by this trial and by all the other publications that has been available at the time being. Regarding the puncture rate failure, as you said, it's more demanding for sure. It's more demanding. It's more difficult, even if you have done a lot of distal radial access out. I still experience some failure. I would say every 15, 17 patients. Sometimes I have an unexpected failure because it's smaller. Sometimes you don't know why you fail, but I would just like to stress that if you fail the distal radial, the wrist is prepared. I just turn the hand of the patient and I go to the conventional radial. So I keep all the benefits of the wrist access. I don't cross over to the femoral. You know what I mean? So yeah. You just have to invest a little bit of your time to try the distal. Most of the time you will succeed, and then you have these advantages in terms of very easy hemostasis, low rate of occlusion, and so on. And if you fail, you just go for the conventional. That's it. So just invest a little bit of your time in. It's not a big hurdle.
I've just a technical question, technical point. Do you use the same intra-artery cocktail that we use for the classical transradial access with heparin, nitro, and verapamil, or have you a little change?
No, definitely the same cocktail. The same cocktail. Coagulation, the same spasmolytic cocktail. Everything is the same. I use an open needle, but some people use the true-to-true technique. So, but all these technical aspects need to be standardized amongst operators. We need to reach a consensus. Sure. So it's not yet well defined. So everybody has his own way of doing it. But but the spasmolytic cocktail and heparinization at the time being is the same. Yeah.
Okay, thank you. And concerning, of course, the size of the distal radial is smaller than the traditional diameter at the traditional puncture site. So is there an impact on the selection and the use of introducer of guiding catheter? In other words, are you limited in the size, 6 French, 7 French? Is 7 French possible through the distal?
That's a major question, Jean. That's a major question. Since it's 1 French smaller than the conventional on average, you have to go for slender technique, sheetless technique. It's very important that you go for a slender sheet. If you use 6 French, use 6 French slender, because it's on average also 1 French smaller than the regular sheet. So it's very important that if you don't use slender, you will end up with more spasm, more failure. But there are some publications and some operators even using 7 French slender, doing CTO and using the distal radial. But probably there is a more selection of the patient. Probably you will not do that in a woman with a small radial artery. You will maybe not be able to use a 7 French slender in such a case. So maybe you have a more selection. But in my experience, I use 6 French slender in all patients.
Okay.
All patients.
Thank you. And finally, it should be my last question. It's concerning the learning curve. I don't know how many cases do we need to feel comfortable.
It's a good question, Jean. It's you have a longer experience than me, but I'm sure that when people have started to use even the conventional radial, they had to really use it in all the cases to get a good experience. I think it's exactly the same for distal radial. You don't do half and half. You have to really invest and try in every patient, the distal radial. So of course, you will have a certain amount of failure, which can be very frustrating for an experienced radial operator, because when you use radial access, the rate of failure is extremely low. So I would say that you will start to be proficient after 50 to 100 cases. But you have to invest a certain amount of your time, and of course, as every learning curve, you will have some frustration at the beginning, but you will be rewarded at the end, especially by the nurse, because I can tell you that my nurse team like very much distal radial because of the hemostasis, which is more easy.
I can understand. I can imagine you. So thank you, Adel, for this brilliant presentation, and I hope that this you will convince. With this presentation, a huge number of interventional cardiologists And thank you again.
Thank you, Jean. Thank you very much.